Lightning webinars are designed to be quick bites of information. This is a very specific type of topic. So there's Amanda. Hi, welcome back. This is a very specific type of topic. So we know that some of the folks on the line may have some specific questions. If you do have any specific questions that you'd like to have answered, please feel free to put those in the Q&A or in the chat. We will monitor that throughout the webinar. Again, this is designed to be about 20 minutes or so, 15 to 20 minutes, depending on questions that we receive. Just those small bites of information. I am noticing it must be cold everywhere because we are all wearing sweaters. So sorry for that, for anybody's terrible weather that they may be having, but welcome Amanda and Christy.
Hello.
So we'll get started. The first place I want to start is just level set. Let's talk about what is place of service, O2, what is place of service in general, and O2, and then 10 as it relates to telehealth. And Amanda, I think I'll let you start, and Christy, I'll let you follow up.
I believe place of service O2, and don't hold me to it, but I believe it came out in 2018 or 2019. Prior to that, when you used to submit a telehealth claim, you would submit it with modifier 95. They changed the manner by which you would report and converted it to a place of service O2. And at the time that they had done that, which was HIPAA creates the POS, CMS accepted the POS and had assigned a facility payment rate to it. This was also prior to the public health emergency when home was not an allowable service. So at the time when you're looking at these encounters, the way that it was presented is essentially if a patient wasn't allowed to be at home but had to present to a location, a facility in order to receive their service, the reason for O2 was to split the professional payment from the practice expense payment associated with the code. So when you billed for your professional service, you would bill with O2, which would get paid at a facility rate. And then depending on where the patient was located, they had the opportunity to use the Q3014 to capture what is known as a practice expense associated with the practice expense of having a patient at the location. So by combining both those claims, technically you would get a full reimbursement for a non-facility payment if it was an office visit.
Great. And anything to add to that, Christy, around the 10 place of service? Because this is really place of service home, where the patient
so 10,
is. Right?
10 was created in what, 2020, I believe.
Right.
And again, that was, so during the pandemic, so just so everyone understands, Medicare still did policy updates to their underlying policies, not just the waivers during the public health emergency. So during the public health emergency, depending on when it ended, they were always planning on extending mental health. In order to extend mental health to home, they had identified a new place of service that would distinguish between a telehealth to a facility, which is allowed under the Social Security Act, as well as telehealth to home, which would be restricted to mental health services. They never implemented it during the PHE, and then post the end of the PHE, they revisited the use of 10. So while looking at 10 as home, they're also looking at, in that circumstance, if a patient is home, nobody is receiving practice expense for the service.
Right.
So as a result, they converted the payment rate for a 10 to a non-facility payment rate, because in that situation, nobody would be submitting for the Q3014, which would be the practice expense associated with the visit.
Right. And patients at home, the idea is there's not any expense, although we could argue that, of course, in this discussion, right? Yeah. Anything that you would add to that, Christy? Amanda's answer was pretty thorough, but I just want to give you a chance.
Yeah, no, she did. Amanda did a great job with explaining not only the codes, but the context. So nothing to add.
So is all of that true for all payers?
No.
No. No, and it's not even, the same per state payer, right? So
Right.
in New York, we actually have a opposite interpretation of 10 by Medicaid. Medicaid's exception for New York is if you want to receive a non-facility rate, that's only applicable in a POS 11. And then for those services, we would report 11 instead of 10. So for Medicaid New York, Medicaid is basing the 10 payment rate still on a facility reimbursement.
And I would say there's even differences between interpretation with our MACs. So
Yeah.
we have various MACs across the nation that are interpreting it differently. And it's really a payer by payer. If you've seen one, you've seen one.
Which is why it makes it so confusing, because some folks are trying to make sense of it and put some standardization around this and not really able to do that. Are there any other modifiers that we should include when considering telehealth from the patient's home? And I'll let you start, Christy.
Well, that if you're using the modifier 10, then in essence, that should indicate, and you wouldn't need the modifier. However, if the payer is not accepting the 10 and would like the place where the patient would have been if they were in person, so reverting back to, like, as Amanda talked about, 11 indicating patient is the office, then the 95 modifier would be expected. So again, that's the payer is going to delineate the place of service that they want you to use, and if they want you to use any sort of modifier. Usually, remember, modifiers are telling you that there's something different about this. So if the CPT and the place of service and the diagnosis code tell you everything you need to know within normal limits of those services, then there should be no modifier needed. If there's a special exception or you're trying to signal them that this is something different, then that's when a modifier would come into play.
Right. And
And
I
the
think
only other thing I would add is so for the place of service 2 and 10, they really represent audio visual. So if you're using audio only, you should still be in report with 93, because otherwise there's no modification. As Christy said, we add a modifier to say we are modifying the way in which we completed this service, right? So if 10 is saying audio visual technology is the default, you would still need your exception for audio only, which is 93 for most commercial insurances, and FQ, which is specific to psych for Medicare.
Correct. Yes, that's a great point.
so.
And I would say that's true for services that have an equivalent in person, but when you're looking at services that are phone only by nature, audio only by nature, or then there's the CTBS, a lot of those codes are not necessarily going to need the modifier or the place of service because they speak for themselves.
And I think that you may have just answered the question that came in live from folks. And this was, can you explain the interpretation of applying both a place of service and modifiers for audio only? Right. So have we covered all of that under that topic, that answer, right?
Yeah, the place of service would indicate it was audio visual, and as Amanda said, if it's audio only, you need to indicate that. Now, that wouldn't necessarily be the case if you're using an audio only code by definition.
Anything else to add to that? Okay, just want to make sure as we're answering these questions as they're coming in the chat, just a reminder, you can add any questions into the Q&A or the chat. We'll review both of them. Q&As will stay in the Q&A section, so you're able to see the answers if those were answered live or they were answered via text. So we have had quite a few questions or topics that have come up in the clients that we've been working with that are having trouble with these place of services when the patient is in fact in a nursing home. Either they're in a nursing home because they are permanently in a nursing home, or they're in a nursing home for an extended period of time because of rehab, because often these inpatient rehabs or these rehab locations are actually inside of the nursing home location. And this is where we're getting these questions, right? Where they might need to see a specialist, and rather than transporting them out of the nursing home, and I'm going to direct this question to you, Christy, and you can add if you need to, Amanda. But patient might be at home in the nursing home, and they would have normally been ambulanced to a specialist location, seen there, and they're trying to avoid that. That's very disruptive for patients, that's particularly in these facilities, and obviously there's an expense associated with it, but the overriding factor is this is a really disruptive process that happens. So what guidance do you have when the patient is in the nursing home, and is a nursing home considered home?
So I would go to, and you're going to have, again, different interpretations around this, but the nursing home, the SNF specifically, so that's the skilled nursing benefit, is eligible for that facility fee. Therefore, if the logic follows, if they're following the interpretation of the reason that the O2 was created, you would use the O2 for a patient that was in a SNF to indicate that it's a facility, and they would be able to bill for that facility fee together, making up the full payment.
And the physician is billing their professional fee as they would otherwise, correct?
Correct, but it would be tied to the facility rate with that O2, because the facility,
they would have to utilize the code set specific to the location as well.
That's where it gets a little bit tricky, and is if the patient would otherwise have come into the office, then it's the established patient office visits. If the physician would have been in the nursing home, then it's the skilled nursing facility codes.
Yeah, so I would have a difference of opinion. So when I look at the telehealth, and again, Christy could, tell you, everyone has a different way of looking at these things. But if we go back to the rules for, and I'm talking specifically for New York, it has to be equal to as in person. When a patient is registered at a SNF, they only receive services from the SNF unless they're discharged. So if the patient is currently admitted to the SNF and you are providing services to the patient at the SNF, in that situation, if done in person, the only applicable way to perform the service would be to perform it at a SNF, because you can't take a patient out of a SNF to an office and bring them back to the SNF. So in those situations, when the patient is admitted, we would consider that you're doing a service to the SNF. You should be privileged at the SNF, and you should be documenting within the SNF record and billing the SNF codes. Now, there's situations, right? Can anyone bring their iPad anywhere and try and do an office visit? You can, and in those situations, I think you have to be, you have to work off of what you know, right? So what is the patient telling you? If they're the one prompting the visit and scheduling it as an office and not indicating that they're at a location, then I think the only information you've received is that you're treating them as an office service. But technically, like if a patient was inpatient, right, their doctor can't just walk into the hospital and start changing medications and treating things. So when we talk about equal to in person, if a patient is admitted, you would not be able to perform your outpatient services during that admission period. You would have to go into the hospital in order to be able to do the services, unless they got discharged and went to your office.
I didn't. And that's where I'm, that nuance I'm not aware of, as far as I was under the impression that they were coming out of that patients were routinely brought into.
There's chances of denials too for being in two different statuses at the same time. So a patient can't be an inpatient and an outpatient at the same time. The patient can't be getting skilled nursing facilities for the same time period that they're receiving office visit services. So if you had submitted an office visit service, there's a potential of a denial for saying that the patient was not applicable for services at the time because they were admitted to a facility.
So these are why we have the questions, because this is a tough one to understand. How then there's so much nuance around it. How are we dealing with these patients when these are real world scenarios that are happening with patients, and we're now allowed to do more flexible services because of telehealth and bring that access to care to those folks that are in a nursing home or in some kind of facility that's not an acute care facility, right? They're in some kind of facility at that point. So what recommendations do each of you have about guidelines or policies related to place of service? And do you want to start, Christy?
Sure. Because we're in this state of flux, I recommend that you look at your patient population, the volume of services that you're doing, and understand and work with each of those, your payers, to understand what they're expecting, what their expectations, and the facilities that you're working with to understand what they're looking for, and make sure that you have appropriate agreements in place, you have appropriate understanding of the billing implications for whatever services you are doing in conjunction with patients who are at these facilities.
And anything to add to that, Amanda?
No, I would just say, like, if you're creating contracts, depending on the location, I would just verify if they are submitting a claim. If they're submitting a technical claim for the patient, then most likely you're going to use an O2 in that scenario. The one situation, which is a caveat, is really the 22 and 19. So that's an outpatient hospital. So as the rules changed during the pandemic, you're allowed to do ambulatory services to a patient from home, even from an outpatient hospital. But in an outpatient hospital, you're not allowed to accept a non-facility rate for your services. So that was the exception that CMS had made to report the place of service of where it would have been done when the patient's at home with modifier 95. And that just ensures that if you were doing an outpatient hospital service that has a technical claim, that you're still only getting the professional payment and not the non-facility payment.
I think that that's helpful. And I think what we've seen when we work with organizations, and all three of us have worked together on these projects too, is when you're deciding between guidelines and policies, to really start to think and have a North Star of, well, what would we do if this patient was an in-person visit, right? How do we handle this guideline? How do we handle this policy if the person was in person? So I think sometimes we see pretty consistently organizations that are telehealth departments trying to kind of take on all of that responsibility themselves versus decentralizing things into the places that they would normally be, like coding and billing experts like yourself, Amanda, and compliance experts like yourself, Christy. So, these are the types of things that that we would recommend on a regular basis to folks. So just kind of keep that in mind. What would you do if they're in person as well? What about other trouble areas related to telehealth documentation? And I'll start with you, Amanda, only because I know this is probably top of mind. When a patient is coming in or when a patient has a telehealth visit, what kind of documentation is required in order to have a successful bill?
Well, so the documentation guidelines really have not changed. So at this time, what we recommend is that you put in the modality utilized, the location of the patient, the location of the provider, and names of any persons that assisted in the service. And then when it comes to physical exam components, I still recommend adding additional narrative. So a lot of templates are already, pre-made, but they imply that a hands-on exam has taken place. So if you're saying abdomen is soft, you don't want anything within your note that questions the integrity of the note. And if you couldn't put your hands on the patient's abdomen, how is the abdomen soft? So we always say add additional items, including patient self-examination that was directed by a physician, or nurse X helped with hands-on exam elements. You just don't want anything to be called out to say that it could not be feasible via audio visual without an explanation. There's still some uncertainty around the rules around audio only. So some recommend during the PHE, CMS has stated that you had to identify why it was not performed audiovisual, but did not give us a medical necessity reasons for what that would be. So at this time, it could still be based on the patient's request for it to be audio only, but that should be within the note. And then depending on your state, Medicaids might have more requirements on when it could default to audio only, including if they don't have access to equipment, or if they refuse to have audio visual. So any of those items you might want to check with your state to see if there's more specific reasons why you could change a modality, or if it's just based on patient requests. And all of those items, depending on what the requirement is, may end up being an additional requirement in the documentation.
And we do see, sorry, go ahead, Amanda.
And then I believe at this time, there's still a delay on the in-person requirement within 6 months. So, but depending on your process, that might be something that needs to be in the note. So if you wanted to make sure you put it in before it goes live, you could always do that, but that's for the potential of within the first year of somebody getting mental health services via telehealth. There's still a pending rule that is overridden by the waiver saying that you have to have an in-person within 6 months of the initiation of telehealth, and then it has to be reviewed annually to see if it's still appropriate. Which that hasn't started yet,
Yeah.
but they may look for documentation within the note for those types of exceptions.
Right, right. And I know that we have seen a good thing you pointed out the individual state situation, because I know we've seen that in individual Medicaid requirements that even audio only is not paid for. So if you have to default there and you are looking for payment, you got to make those additional pieces of documentation or assume that you won't be paid for that visit. I want to make sure that I ask this last question that's coming into live, because we are over time on our standardization of hopefully 20 minutes for these sessions. But the person is asking, so if telehealth services, I'm going to try to be very specific on what they ask. So telehealth services are being provided from, if telehealth services are being provided from ambulatory outpatient hospital to patient at home, what place of service and modifier would be appropriate? And if the patient is on a different campus than the provider, not at home. So those are two separate scenarios. So do you want to jump in?
First scenario,
Yeah.
You would report the hospital POS, right? So a hospital for the professional claim. So for the professional claim, when it's performed in an outpatient hospital setting for a Medicare patient, right? Because again,
To a patient at home.
Yeah, your state rules might be different. For a Medicare patient that initiated from a hospital setting, like a 22 or a 19, and is a visit to a patient at home, you would bill 19 or 22, which defines the payment rate as non-facility, and then the modifier 95, because that's the area in which the potential of the Q code might be allowed or the G code might be allowed, but a professional in those settings is not applicable to receive a non-facility payment, because that's inclusive of practice expense, which is not included in their payment. Sorry, that was a lot.
And the second part of that, if the patient's on a different campus other than the provider and not at home. So if they're on a facility campus, but not
Yes.
at home, say for example, from one PCP office or an ambulatory clinic to a specialty office.
So that would be an O2.
Okay.
Yeah. So if the patient is not at home, then 10 is not the answer. Yeah.
And any other modifiers, just to let them know, the 95, to let them know that there's something different.
That would be so for audio visual, if you're reporting a 2, you don't, for Medicare, you don't need a 95. But if it's audio only, you would need the audio only modifier.
Thank you, Amanda. And Christy, any thoughts around that in terms of the way that we need to think about policy or compliance?
No, it's going to change over the next year, and it's just you recommend that whatever cadence you would normally watch, that you quadruple that cadence of review, because things are changing so rapidly.
Really good advice. I think that we've been recently giving folks advice to look at their policies and procedures around telehealth at least once a year. And given that flux that we're looking at, that you may even want to look at them every 6 months, especially, and get a contact in your coding department and your billing department so that you can get the experts like Amanda and Christy. We did go over, but we knew this was going to be a hot topic, very specific, very, these are very specific questions that folks would have. So thank you guys for being so specific today. Thank you.
Only other thing I would recommend is try to find someone in your MAC, or at least sign up for alerts from your MAC, because even when you get it right so far, Noridian and NGS have come out saying that even if you're reporting 10, they're not paying it correctly. So those are things to keep in mind if you want a notification. If you don't have a process to track underpayments for that place of service, which a lot of places might not if they just started utilizing the POS.
I think that is really, thank you for stopping me and closing and pointing that out, because we're looking at the max, and I think maybe 60% of them are Noridian. So something to consider. You can look that up. The max are all divided by region if you aren't aware of that. It's definitely something to be taking a look at. It's not just a connection to your CMS, that definitely you need to have a connection at CMS in your state for Medicaid, et cetera. But yeah, the Noridian is going to be the decider and a lot, or the max will be a decider in a lot of these. So thank you for pointing that out. Okay, folks, I think we're close to the end here. We're only a day away from the end of February. Thank you all for coming to the webinar today and participating. If you do have any other questions post-webinar, you can post them in the survey that will pop up afterwards. And if you have any topics that you would like us to cover, we like to do these webinars on short little bites of information. So if you have any topics, and then longer webinars that we do with panels for larger topics that may need more discussion, you can put those in the survey afterwards. Amanda, Christy, thank you so much for being here. Always a pleasure.
Thank you.
Thank you. Bye.